I want to talk about the importance of using health technology to structure the patient-provider encounter to prevent mistakes, and so that we have real good quality data for the public good. Um, I've been working as a physician in the emergency room in the hospital ward since the beginning of the pandemic, and I have to say that it's been sort of just a continuously scary experience. Um, it's not because of bad intentions, but by definition, doctors don't train on novel pathogens. There's a lot of confusion during and even now about what were the recommendations. We were told at the beginning of the pandemic, for example, that there were 1 million swabs out there, but I swear there weren't any swabs for at least a week to test patients about COVID-19. And so we did our best, but most people would agree that we could have done a lot better, including the patients. You know, in the ED, we often discharge people on Tylenol and cough medicines and just told them to go back and quarantine, knowing that the details and the support for quarantine wasn't really going to happen. If patients were admitted, they were put on chloroquine and azithromycin. The studies had shown in many other countries that this was not an effective therapy. Later, we learned a lot, including that chloroquine kills people, and we still could not disseminate that information beyond our individual facilities. And meanwhile, public health departments essentially pleaded with us to call them when we had deaths, if we had certain types of cases. And because we were busy, I would say more often than not, we did not answer the call. So, you know, sharing matters, and I think especially in the current social upheaval that we see outside in our streets, that we can draw an analogy that the healthcare system needs a type of virtual body cam. The idea of this is that this is an important enough endeavor that multiple eyes increase the performance on the prize, and that we should be happy to add transparency to things of importance. And this doesn't have to be a scary thing. You can imagine that the body cam of the 21st century is not just a recording instrument. It can actually help the wearer, let's say, decide if a situation is dangerous or not, or if a treatment is appropriate or not, or if a pre-treatment just is plain dangerous. Doctors, you know, so here's the current body cam that we have in the system. But I have a company that produces a different type of body cam. So in this system, what happens is that the provider, when after seeing and examining the patient, they decide on what is the diagnosis. And in this case, I'll just pick Kawasaki's disease because a lot of people have been worried about that in the pediatric environment. And they select what they think that diagnostic, and then they provide care with support. So in this example, that the provider is told explicitly that the diagnosis of Kawasaki's depends on fever and 4 exam criteria. Now, some providers might not know all those criteria, so they can actually look in line with their care and say, okay, that is what the oral mucosa changes looks like in Kawasaki's disease. Or, did I see the right thing with regards to the hands and feet? Oh, no, that was not what I saw, et cetera, et cetera. And as they complete all the lists, the diagnostic criteria, then the system actually gives them a grade. And in our system, you can actually see what constitutes a grade of a quality diagnosis by looking at a rubric about documented actions in care. Just really another quick example in treatment. Doctors are actually okay with getting support as long as they know that there's science behind it. So in this example, we could see that in our charting, that the provider can click on a reference to say, okay, what constitutes the background, and then click the article itself to see that, okay, yeah, this thing is something that I can agree with. And having that, they have no problem adhering to protocol, including not giving chloroquine or antibiotics for treatment of Kawasaki's, because that's dangerous. And they verify this in our system. But things like immunoglobulin therapy, aspirin therapy, no problems with the recommendation. You don't even have to do it if you don't want, but it does give you a grade. It does do automatic dose calculation. And again, for such an important outcome situation, people deserve, the public deserves, the provider deserves public health bodies deserve to know what constitutes complete care. So indicators matter, and you can imagine that by structuring care in a way that we can then not only look at Kawasaki's disease, but look at all other diseases. And we have about 275 diseases and conditions that we look at. And then what we do is that we de-identify, aggregate, and then we publish this for public health bodies so that they can see what is the health status of the community, where are the hotspots, where are the success stories, and share that information to the public and devote essential resources to important things. So in this graphic, which our providers can always see and our public health bodies can see, it's not only Kawasaki's and coronavirus that are important, it's all the diseases. And then you can see the performance on the diseases based on those rubrics that you saw further. And God forbid there's things like deaths, but sometimes it is important to realize so that no life goes wasted. What are the details with regards to that case? And in real time, certain people in our system can open up the chart and see that how individual provider patient quality data is directly impactful to the public's health. So I'll stop right there because I know that was just really introduction to our system and my sort of line of thinking. Thank you so much.